No. All right. So our outline, we're going to be discussing, apart from blood donation, we'll still have blood group antigen or something like that. But for this lecture, we are going to look at blood donation. Looking at blood donation, we have the history of blood transfusion, how donor selection, donor preparation, and the blood donation itself, types of blood donation, types of blood donors, blood components. We are looking at basic blood components, preparation, preservation, storage, clinical indicators, okay, pre-transfusion testing, blood banking processes, organization, structure, facilities, records. We have alternatives to blood transfusion. You know, some religious organizations, I don't know if they have changed for now, don't really take blood transfusion. So autologous blood transfusion, pharmacological measures to reduce transfusion, thrombopoietin mimetics, parenteral ion, and also the WHO guidelines of assessing donor suitability for blood donation. This will be an assignment. So the class rep should come, we'll discuss further on that. So at the end of this lecture, you are expected to understand the care and selection of whole blood and components, donors and components, including laboratory investigation, quality assurance measures at blood donor session, collection of blood or component donation, evaluation and describe blood component production and processes, understand clinical indication for blood components, describe the standard for blood bank and transfusion services, organization, equipment, process control, etc. Know and understand the alternative to blood donation, transfusion. Okay, the history of blood transfusion. The use of blood as a product dates back to the 17th century. Okay. There were numerous examples of references in the Bible of the use of blood, which were considered as the very essence of life and synonymous with same. Okay. There are some scriptures that talk about blood. So, but one of the earliest accounts of circulation of blood was by the Arabic scholar, mathematician, and physician Ibn al-Nafis, who in 1260 AD described the minor circulation of blood in the body. This was more than 250 years before William Harvey, the one we popularly know, described the circulation of blood around the body in 1616, which it published in 1628. So some of the milestones as regards blood transfusion, we will not dwell much into it. You can read that on your own. Between 1660 and 1670s, the well-known physician William Harvey discovered the circulation of blood. Also, the microscopists Jan Swaminathan observed and described red blood cells. Okay, in the 1980s, 18s, the British obstetrician James Blundell performed the first successful transfusion of human blood to a patient for the treatment of postpartum hemorrhage. The 90s, Karl Landsteiner, an Austrian physician, discovered the first three human blood group, and so many other discoveries that followed each step of the way of the discovery, building on previous discovery and diagnostic procedures. That's what we outlined there. These are some of the key scientists or the initial scientists that really worked hard on blood system. You can find some of their faces here. Okay. So donor selection or recruitment, preparation, and then the donation. Then we also have types of blood donation and types of blood donors. WHO guideline for assessing donor suitability. The class rep should meet me so that we know how we are apportion this for your assignments. Okay. So, but essentially, we should know that unpaid volunteers donating regularly are key to the provision of safe and sufficient blood for transfusion. Those that are not out for making money with blood donation. 17 from 17 years to 65 years olds can enroll as first-time blood donors. These are some of the key points, some of the essential points you know about blood donation, blood donors. To ensure the safety of the blood and recipients, a medical questionnaire, there's a questionnaire covering health, lifestyle, travel history, medical history, and medication is completed before each of the donation. You don't just invite somebody, or somebody cannot just volunteer to donate blood without the facility taking some history or some eligibility checks to know whether the person is fit to donate in the first place, whether it's paid donor or voluntary donor. The minimum mandatory infection screen on all donation for hepatitis B, C, HIV, HTLV, and syphilis. Donation are routinely ABO and resource typed and screened for clinically important blood group antibodies because of some reactions that may come up. Modern transfusion practice is based on the use of blood components rather than whole blood donation. We'll still see that in detail. Plasma derivatives are licensed medicine and include albumin solution, coagulation factor concentrates, and immunoglobulin. Okay, so donor selection guidelines, DSG. This include their guidelines for selecting donors for bone marrow and peripheral bone stem cell donation. There are guidelines for selecting donors for cord blood donation, disease donors for tissues, geographical disease risk index, live donors, live donors, that's for tissue, that's for tissue. Some persons that donate, maybe somebody wants to donate kidney or so there are guidelines. So but we are looking at whole blood donation. We are precisely discussing blood in this lecture. We are not talking about bone marrow, we are not talking about stem cells, we are not talking about cord blood. We are zeroing in on blood donation, whole blood and components, donor selection guideline. That is our focus. So what is donation? Blood is considered a drug, and all aspects of the selection of donor, both the collection, processing, testing, preservation, and dispensing, are regulated by the FDA, that is for America and Europe, as specified in the Code of Federal Regulation. We have types of blood donation and we have types of blood donors. You should know that very well. Then types of blood donation, we have allogenic blood donation, that is volunteer blood donation. We have autologous blood donation, where you donate your own blood, maybe in some selective or planned surgery. Someone can donate his or her own blood, bank it until the time of the surgery when the person will need it. Directed donor blood, patient-specific donation, probably due to antigen antibody identified. Therapeutic bleeding. Okay, so some persons with some persons with excess blood polycythemia, some cases of polycythemia vera, some persons will tell you blood in excess, that when they bleed it, when they donate it, they feel okay. So that's what we call therapeutic bleeding donation. Okay, so allogenic blood donation or volunteer blood donation. Blood donation originating from an unrelated donor are known as allogenic blood donation. Autologous blood donation, okay, are situations where an individual can donate blood for their own use if the need for blood can be anticipated and a donation plan developed. It's most commonly in elective surgery. Explain that. Autologous blood transfusion can be obtained by pre-operative donation, acute pneumovolemic hemodilution, intraoperative salvage, post-operative salvage. These are some of the situations where they can also uh, get autologous blood donation, either pre-operative donation or intraoperative salvage. They try to return back the blood to the patients, or post-operative salvage. Autologous donor may donate as often as 72 hours every 3 days prior to the planned surgery. Erythropoietin and iron can be given to increase the number of units they can donate. Its contraindications: bacteremia, symptomatic angina, recent seizures, symptomatic valvular heart lesions. So in some of these conditions, autologous blood transfusion are not advised. Okay. Direct donor blood. These are friends or relatives who wish to give blood for a specific patient because the patient hope that those donors will be safer than the regular blood supply. Risk because of information withholding. But you find out that some of these direct donors don't give all the information that are required, or they may hide some information. That is the risk attached to this type of donors. Patient-specific donation, blood from a particular donor for a particular patient. For example, donor-specific transfusion prior to kidney transplants. Maternal platelet for a fetus projected to have neonatal alloimmune thrombocythemia purpura. Family members of a patient with a rare blood type. So this patient-specific donation is usually needed in situation where there are some rare antigen or antibodies that are being considered, and when such donors are encountered, their blood sample are specifically left for some specific patients with such rare blood groups. We also have therapeutic bleeding. Blood can be collected as part of disease management. For example, polycythemia vera, hemochromosis. Okay, so in situation where some persons, they will tell you that their PCV, their hemoglobin concentration is quite high. So sometimes they are relieved of some headaches when they donate blood. I will call it therapeutic blood donation. Now, blood component preparation. Blood components are prepared either from whole blood units or from apheresis method. We'll still see that what it means as we go on. Blood components are preparation are made possible by the introduction of multiple pack plastic bag by C.W. Water in 1949. Blood component make it possible to transfuse only that product of the blood that the patient needs. So when we collect blood as a whole, without separating anything, we call it the whole blood. But in patient management, okay, it's not advised to always give patients whole blood. Okay, so patients are attended to or are transfused any of the blood components based on their disease condition. For example, a patient that is anemic, you know, the hemoglobin is going down. What he actually needs is red cell. It's not advised for him or her to be transfused with the whole pack of blood. The best practice is to separate the plasma from the packed cells and then give the patient the red cell, the component of the blood that is needed to manage. Sorry about that. So importance of blood components separation. It's very, very important because it provides optimal survival of each component. Okay. Transfusion of only desired components to the patient. Use of unnecessary components is avoided because there are complications that comes with it. Several patients can be treated with blood from one donor, assuming a donor donated a whole blood. From that whole blood, you can separate the red cell, okay, concentrate, and give to a patient that is anemic, like a sickle cell patient. You give packed cell, that's what they need. Then another patient may need coagulation factors. You separate the plasma, okay, prepare a cryovirus, then give to the patient that needs coagulation factors. He doesn't need the red cells, okay. So that is what we are trying to say. So when you look at this slide, you see the patient that donated blood. We call it, when we collect blood from a donor, okay, we call it the whole blood. Then this whole blood are made up of a lot of uh, constituents or components. When you can find the first, when you separate the cells from the plasma, we have the plasma components, we have the cellular elements. Okay, so under these cellular elements, we have the red blood cells, we have the white blood cells, we have the platelets. Then the plasma makes up 55% of this whole blood, while the cellular components make up 45% of the uh, whole blood. So the whole blood can be separated into its various components. Okay, you can separate the plasma, and even from the plasma, we can still go further to separate what we call precipitates, for that is the blood coagulation factors. Okay, then from the cell components, we can still separate the cells using available equipment like the apheresis machine. We can still separate the cells into their various types. We can still get platelets from these cell components. We can separate the white cells also. We can separate the red cells, components of the blood, to give it specifically to the patient that needs it. So the plasma component contains water, contains protein, and other solutes that are also present there. Okay, so each of the components of the whole blood can be separated, okay, and administered to patients as they need or as they require. It is not advisable to give whole blood to patients based on best practices, except in situation where the patient is losing blood, like in accident cases. The patient is losing both cells and volume. Okay, he's losing both the plasma and he's losing both the cell. In a case of active bleeding, like in surgeries or accidents where the patient is actually losing everything he has, you can give whole blood. But in a patient that is probably sickle cell patient, this patient is not actively bleeding. The problem is having is that his red cell are being destroyed and the oxygen carrying capacity of these red cells are reduced. So he already have the volume inside his system, but he needs to beef up, he needs to increase his red cells and their oxygen, so that the oxygen carrying capacity will also increase. So what he needs is the packed red cell. So when you give him packed red cell, you are saving him from one of the complications of blood transfusion, which is circulatory overload. Because in as much as he's not losing blood actively, if you keep on transfusing whole blood to such patients, you subject the patient to complication of blood transfusion. Okay. So blood components, as we saw in that diagram, we have cellular components, the red cell concentrates, the white cell, platelets, leukocyte reduced platelets, platelet apheresis, white cells apheresis. Okay, we have the plasma components. We can get fresh frozen plasma. We can get a single donor plasma, cryoprecipitate, cryopore plasma. These are some of the components we can get. Plasma derivatives, we can get albumin, we can get plasma protein fraction, factor 8 concentrate, immunoglobulin, fibrinogen, other coagulation factors. If you have the specific instruments, equipment, these can be separated from the whole blood. But the basic blood components we have are the whole blood, the red blood cell, the platelets, fresh frozen plasma, and cryoprecipitates, and we will discuss these basic ones. So the whole blood is the unprocessed donated blood. It contains red blood cell, plasma, platelet, coagulation factors. It has not been processed. This, as it's being collected from the donor, can be used only up to 35 days after it has been drawn. Okay, 450 ml whole blood in 63 ml of anticoagulant preservative solution, of which hemoglobin will be approximately 1.2 gram per dl. And then the hematocrit is 35-45 with no functional platelet or labile coagulation factors when stored at +2 to +6. Yes, platelets will not be there because normally platelets are stored at room temperature with constant agitation. So when you store at fridge temperature, you will lose the platelets. The infection risk, the whole blood is capable of transmitting an agent present in cells or plasma which was undetected during routine screening. Okay. Transfusion transmissible infections like HIV, hepatitis B, C, syphilis, and all that. So there is risk of transfusing some infections with whole blood. Okay, a unit of whole blood, like we said, then the hematocrit is this percent. Okay, whole blood stored longer than 24 hours has few viable platelets. Say that. Okay, so storage, it is stored between +2 to +6, that is fridge temperature. Okay, in an approved blood bank refrigerator. You know, the blood bank refrigerator is different from domestic refrigerator, fitted with temperature monitor and alarm indication. Okay, whole blood transfusion is indicated or is advised when we need red cell replacement in acute blood loss with hypovolemia. Just like I was giving an example with an accident case or in a surgery case where the patient is actively losing volume. Okay, because during the accident and somebody is losing blood, if you don't replace the blood, the person will go into hypovolemia and may die. So exchange transfusion also, we can give whole blood. These are the situations where whole blood can be advised. Now, its whole blood transfusion are contraindicated in some other conditions because of the risk of volume overload in patients with chronic anemia, like the sickle cell patients, incipient cardiac failure. Okay, administration. Before you can give whole blood, you must ensure that there is ABO resource compatibility with the donor, between the donor and the patient. Never add medication to a unit of blood. Complete transfusion within 4 hours of commencement to avoid contamination. Red blood cell concentrates. Okay, so as a component of blood, we have red blood cell components. If you look at this slide and look at this picture, you can see a pint of blood that have been allowed to stay for some time. Then insert it into this machine and try to remove the plasma. You can see as it presses this knob, the plasma separates from the whole blood and is being collected, harvested into the other bag. So red blood cell contain hemoglobin, which is a complex protein containing iron that carries oxygen through the body. Who is raising up their hands? Do you have any question? Do you have any question? Did I do it? Okay, so I should go ahead.
I have a question, ma'am.
What's your question?
My question is, like, a pregnant woman, can a pregnant woman donate or receive blood?
What is the situation of anybody can donate if she meets the criteria for donation? If the criteria for donation is that a pregnant woman can donate, then the hemoglobin is high. Know that the criteria for donation, she will not meet the criteria for blood donation. So it depends on the condition. The doctors know how to manage them. Most of the time they use hematinics on them. I don't think the criteria for blood donation, I don't think a pregnant woman will meet up with those criteria. All right.
Thank you.
All right. So we have red blood cell concentrates. Red blood cell contains hemoglobin, a complex protein containing iron that carries oxygen through the body. We all know red blood cell, and it's a component of whole blood. So this is how we can separate it from the blood by removing the plasma portion of a settled blood bag. Okay. Preparation: red blood cell is prepared from whole blood by removing plasma. By removing the plasma, that is what you are seeing on this picture here. Okay. By removing plasma. Improvements in cell preservation solution over decades have increased the shelf life of red cell from 21 to 42 days. Red blood cell may be treated and frozen for an extended storage of 10 years or more, where you have the facilities and the necessary conditions and everything. So we can separate red blood cell. In the process of getting the red blood cell, we can do what is called pre-storage leukocyte reduction. When you come into fourth year, when we'll be discussing about transfusion, complications of transfusion reaction, you will appreciate this process of removing the white cells before storing the red blood cells. Red blood cell requires special preparation by removing white cells by filtration shortly after donation. This is done before storage because high numbers of white cell remaining in a unit of red blood cell during storage process can fragment, deteriorate, and release cytokines. See what the white blood cells can do if you leave them inside the red cells. That is, it's good to remove them from the red cell. When you've separated the red cell, it's good to also, there are some filters they use for that, to remove the white blood cells because they can release cytokines. They can release cytokines when they get agitated, and those cytokines, if they release it in the blood that you stored, upon transfusing that blood to a donor, you can initiate some complication transfusion reactions. So it's to prevent some of the complications of transfusion that it's advised to remove white cells before storing red blood cells. So under what conditions or situations can we use red blood cell donation? To increase oxygen carrying capacity in the following settings. Okay, treatment of chronic symptomatic anemia in patients unresponsive to conservative therapy, or when medical necessity does not allow time for conservative therapy. Okay, so in such conditions, we can give red blood cell. Treatment of an actively bleeding patient from trauma surgery, can also give red blood cell. The dose response, okay, this is the dose. We can, in an average adult of 70 kg, one packed red blood cell unit can increase the hemoglobin by 1 gram per dl and the hematocrit by 2 to 3%. Infants 10 to 15 ml is given to them per kg to achieve the same response, because in adults, we give the 450 ml that is being transfused to the adults can increase their hemoglobin by 1 gram per dl and increase the hematocrit by between 2 to 3%. But in infants, the volume of blood that is being given is 10 to 15 ml, and that 10 to 15 ml can also achieve the same 1 gram per dl of hemoglobin and 2 to 3% of hematocrits. Okay, so packed red cell transfusion are not advised. They are contraindicated in some situations. Transfusion of red blood cell is not indicated when restoration of blood volume and symptomatic relief can be accomplished using crystalloids or colloids alone. Generally, when blood loss is less than 20% of the blood volume. So in some situations, they don't need it. Like we always say, you said earlier that blood transfusion is form of drug. And also, when you look at the complications of transfusion, you find out that blood transfusion is not a process. It's not a process that is 100% risk-free. No, it's not. It has some attendant risk. In fact, the best practice is, if there are no more other alternatives, then you can go to transfusion. But if there are alternatives like they're saying here, colloids or hematinics, or giving hematinics or erythropoietin, iron and all that, if there are still time to do those, it's better you take that line. But if there are no time, there is a question of 50-50 chance. If you don't give blood, you have adverse events. So you can now go ahead and give blood. But blood transfusion should not be the first line of thought to manage anemia. So we also have another blood component. Okay, we can also get frozen red blood cells. preparation, we can prepare frozen red blood cell. Okay, they are freeze with 40% glycerol and they are stored at -65 for 10 years. I think the white men do this a lot because they have the facilities and the necessary equipment. It can be thawed at 37 degrees for 30 minutes. Okay, then deglycerolization, okay, performed to remove glycerol prior to transfusion, must be within 24 hours. Okay, deglycerolize, wash with solutions of decreasing osmolarity of sodium chloride. Okay, these are specialist practices that I don't think we practice here, but red blood cell can be frozen. Indication for preparing frozen cell phenotypes units. Why is it necessary for preparing frozen cells? In some situations where they have types on units that they have some rare antigen, rare blood groups that may be needed in the future of needed for particular procedure in some patients that we have some rare blood groups. So if they come in contact with such units, sometimes they want to preserve it for a particular patient that may come up that may need it, or for a patient that need it, that specific rare blood group, so they can decide to actually store it. Okay, autologous units, if compatible allogenic units are difficult to find. Okay, so in situation where also a patient donates his or her own blood for a planned surgery, it can also be stored for them this way. So platelet concentrates, they are small blood components. We know the platelets formed by fragmentation of megakaryocyte membrane extensions. They are important in maintaining hemostasis, help stop bleeding, and form a platelet plug. So the platelets involved primarily in blood coagulation. So they are very, very important in the body. They are needed by cancer patients, bone marrow recipients, post-operative bleeding. They can help manage such conditions. Preparation of platelets from whole blood. So to prepare platelets from whole blood, as you can see in this diagram, this is whole blood. Okay, we require 2 spins. Okay, we require soft spin, separate red blood cell and WBC from plasma and platelets. Then we do what we call heavy spin to get platelets in platelet-rich plasma. Okay, so because the platelets will be forced to the bottom of the bag, so there's a lot of blood bag connections. There's a lot of bag connection. A lot of bags are linked. The first one, okay, light soft spin. The plasma that you produce is what we call platelet-rich plasma. Those plasma are rich in platelets. Then we call a heavy spin to separate the plasma, and then the platelets under will settle on the next bag. Okay, so we do a soft spin, collect the platelet-rich plasma, do a heavy spin, separate the plasma from the platelet concentrates. That's how we get our platelet concentrate. I think we have that facility at UNTH. People should look out for it and see where they are practicing it. Okay, the storage temperature for our platelets is 20 to 24 degrees centigrade, and we can store days with constant agitation. So platelets, to store platelets, they are placed on top of a platform where they can be rocked, agitated, that is, move back and forth. so that they don't pack, because once they pack, they tend to adhere to each other. So to prevent that adherence or clumping of the platelet together, they are stored at room temperature with constant, we call it agitation, constant rotation, movement, constant shaking. Okay, each unit should contain at least 5.5 raised to power 10 platelets. Each unit should elevate the platelet count by 5 to 10,000. Okay, so types of platelets, we have pooled platelets used to reach therapeutic dose. An open system occurs when pooling platelet, that is from different persons. So you can't store platelets at room temperature for more than 5 days. Note that. It's okay. We can get pool platelets. We can get platelet through apheresis, therapeutic dose from one donor without having to pool platelets. I think you should go to blood units and inquire about the apheresis room where they do this type of process. I think we have it in UNTH. It will be good if you can go there and look at the process, how they do it. HLA matched for those with HLA antibodies which have leukocyte reduced, used to prevent febrile non-hemolytic reactions and HLA alloimmunization. So sometimes we have platelets, when we do platelet apheresis is from one donor. Okay, so probably a donor that is meant to donate for someone having kidney transplant or something or the other, you don't need to use pooled platelets. The donor that have been cross-matched for that patient can also undergo apheresis and separate enough platelets, because through the process of apheresis, enough platelets can be generated for a patient. You can see the concentration 3 times 10 raised to power 11. It's quite huge. So platelet products, we have platelet concentrates, we have platelet pheresis. Okay, so dose and response. On average, in an average adult, platelet concentrates are usually administered in pools of 6 units. Okay, one platelet concentration increase the platelet count by 5 to 10 times 10 raised to power 9. Okay, so you can see what it can add to the patient. Okay, a single platelet product should increase the platelet count by 30 to 50. Okay, an adequate response or need for further therapy should be guided by comparing the pre-transfusion platelet count to a platelet count measured within 1 hour of the completion of the transfusion. So before another platelet concentration is being given, you have to assess the increase of the previous transfusion. Cause for an inadequate response to platelets. Sometimes when we give platelets, we find out that the anticipated increase we are hoping to, our target increase, we're not able to achieve that. There are some reasons, there are some causes to that. It may be due to immune mediated, it may be as a result of an immune mediated response, presence of HLA alloantibodies, platelet auto or alloantibodies may be non-immune due to DIC, fever, infection, splenomegaly, or other medications. So platelet is indicated or can be used for prophylaxis in patients with count less than 10,000, 10 to 20,000. So you ask yourself, what is the normal count for platelets? Okay, so these people have less than 10, between less than 10 to 20,000. Okay, usually in the setting of myelosuppression, people that are taking myelosuppressive drugs from chemotherapy. Okay, they can be used in treatment of patients with count less than 50, okay, who are actively bleeding or are preparing to undergo an invasive surgical procedure. Treatment of patients with count less than 100,000 who are bleeding in cardiopulmonary bypass surgery, neurosurgery, ophthalmic surgery. Treatment of patients with platelet function defects and bleeding can be congenital, can be acquired. So these are some of the conditions where we can use platelet transfusion. The role of platelet transfusion in special clinical setting. The role of platelet transfusion in special clinical settings. In special situations, there are some roles that platelets are very important. Okay, in TTP, this is a microangiopathic hemolytic anemia accompanied by consumption of platelet resulting in neurological and renal dysfunction and fever clinically. So in this situation, there is consumption of platelets, and that is what is reducing the patient's platelet count. So we need to give platelets, but sometimes platelets are considered to be contraindicated in TTP unless there is life-threatening bleeding, may add fuel to fire. Okay, so what that means is that in a situation where a patient is having low platelet count, okay, you need to find out first what is happening, what is consuming the platelets. Why are the platelets reducing? Okay, because if you don't establish the cause and add more platelets, it may be that what you are actually doing is that you are adding fuel to fire. Okay, so the cause of the platelet reduction in TTP has to be established first. Okay, treatment may be plasma exchange. Plasma exchange is treatment of choice for TTP. Okay, so we have heparin-induced thrombocytopenia, another clinical condition. It's caused by antibody directed against heparin platelets P4 complex, leading to platelet activation, resulting in thrombocytopenia and thrombotic complications in some patients. Best option, discontinue the heparin. Platelet count rises in several days. Eliminate potential sources of heparin. Okay. Heat is essentially a thrombotic disorder, thus platelet rarely needed, may add fuel to fire. So these are some of the clinical scenarios where we have to be cautious in trying to transfuse platelets. We have ITP also, which is as a result of autoimmune destruction of the patient's platelets. Okay, it's mediated most often by anti-G glycoprotein 2b3a. Okay, transfused platelets similarly rapidly destroyed. Transfusion not effective if goal is to raise count. Consider only if there is bleeding. Other treatment option, giving immunoglobulin, splenectomy, steroids. Usually not necessary to transfuse patients with platelet before and during splenectomy due to release of sequestered platelet count. Sequestered platelet count will usually rise. So this is a situation where there is an immune destruction, autoimmune destruction of a patient's platelet. That is, the immune system of the patient is destroying the patient's platelets. So that even if you add more platelets to the patient, the immune system of the patient will also destroy. So why they are advising when you give is that when you give reduce the attack, they will help to reduce the attack. They will help to reduce the attack on the platelets or splenectomy, because it's from at the spleen that this immunoglobulin are being produced. So we also have aspirin use. Aspirin, what it does is that it irreversibly inactivates platelets for the remainder of their lifespan. So aspirin normally inactivates platelets. Okay, so if a bleeding patient has been taking aspirin, transfusion may be needed regardless of platelets count. Okay, aspirin should be discontinued before platelets transfusion. However, aspirin is rapidly metabolized, thus only 1 to 2 hours need to pass after the last dose of aspirin before platelets can be transfused without exposing them to the irreversible effects of aspirin. So because aspirin inactivates platelets, patients taking aspirin can be given platelets concentrates. Also, in situation of toxicity like in uremia, uremia can cause platelet dysfunction. Okay, transfused platelets almost immediately becomes uremic platelets. Thus, transfusion of platelets is not indicated. Okay, you can't give platelets in this situation where the transfused platelets are also rendered inactive. The treatment option is to keep the hematocrit between 25 to 30 or above. Okay. Dialysis to remove platelet toxins. You can see it. DDAVP facilitates von Willebrand release and possibly enhance platelet adhesion. However, new package insights state that DDAVP is considered contraindicated in patients with moderate to severe renal impairment, cryoprecipitate conjugated estrogens. So these are some of the treatment options in uremic patients. In situations where we also have congenital platelet defects, including Beniasulia syndrome and Glanzmann's disease, okay, in a bleeding patient, platelet transfusion may be needed regardless of the count because it's losing the platelets. Prophylactic platelet transfusion not advisable because of risk of alloimmunization to HLA and RBC antigens. So in some of these clinical situations or scenarios, we are cautious about platelet transfusion. So we also have ABO and resource compatibility issues. ABO are expressed on platelets, but weakly. They may give platelets out of group due to inventory issues. So because of the ABO antigens are also present on the platelets, they can give some blood grouping variations in trying to type patients. However, poor response to platelet transfusion sometimes occur due to clearance of ABO incompatible donor platelets. Okay, can carry ABO compatible platelets to see if response improves. Due to the small blood volume of neonates, exposure to ABO incompatible plasma should be minimized. Use ABO compatible platelets only or reduce the plasma volume of non-ABO compatible platelets. So these are some of the best practices in some of these clinical scenarios. Resource antigens are not present on platelets, but platelet concentrate may contain some contaminating red blood cells with resource antigens. In general, platelet concentrates have less than 0.5 mil red blood cell. Apheresis platelets have less than 2 mil. Okay, so all these things are for our information attention on preparing blood for donation of platelet concentrate or advising the clinicians, there are some clinical scenario that you need to consider whether it is advisable to give platelets, although the platelets may be low, like in the TTP or in the autoimmune purpura, where the patient autoantibodies are destroying the platelets. Okay, although the platelets are low, you can't still give platelet because it's like adding fuel to the fire. So another product we have is the fresh frozen plasma. The plasma that is frozen within 8 hours of donation. That is from the time of donation to preparing the fresh. You need 8 hours from time of donation to prepare this components of the whole blood and also to freeze it. You don't leave the blood, maybe the blood they donated today, you leave it, say tomorrow you will come and prepare the fresh frozen plasma. No, within 8 hours of collecting the blood, you've prepared the fresh frozen plasma and you have kept it at minus 80 degrees centigrade or colder. It can stay there for 1 year. Provides coagulation factors for bleeding. Can provide coagulation factors. Okay. Abnormal clotting due to massive transfusion. These are where it can be needed. Patients on warfarin who are bleeding. Treatment of TTPS, TTP and HUS. Factor deficiencies, antithrombin 3 deficiencies, DIC, when fibrinogen is less than 100. So these are some of the conditions, situation where we can use this fresh frozen plasma. Fresh frozen plasma is thawed before it is transfused. Thawed at 30 to 37 degrees centigrade for 30 to 45 minutes in a water bath. Stored at 1 to 6 degrees centigrade and transfused within 24 hours after we have thawed it. Okay, it also needs to be ABO compatible. Okay, we all now have cryoprecipitate, another component of the whole blood. Cryoprecipitate is, we refer to it as the anti-hemophilic factor. We refer to it as being rich in factor 8, and it's precipitated protein portion that results after thawing the fresh frozen plasma. So to get the cryoprecipitate, we must have prepared the fresh frozen plasma, and then in the process of thawing this fresh frozen plasma, we can now harvest the cryoprecipitate. It's made by thawing fresh frozen plasma between 1 to 6 degrees centigrade, not 30 to 37, the one for transfusion. This one, you thaw it at 1 to 6 degrees centigrade, still in a cold environment, and recovering the cold insoluble precipitate, which is then frozen. It contains a number of clotting proteins to help control bleeding. It is stored frozen and thawed when required. You can see the process here. It's already a fresh frozen plasma. Then we thaw it at between 1 to 2 degrees centigrade in a cold environment, and then harvest the precipitated harvest the cold precipitated insoluble precipitate. Then we harvest it. When we now harvest it, that forms our cryoprecipitate. This plasma cryoprecipitate. Okay. It contains von Willebrand factor, fibrinogen, factor 8, and fibronectin. These are some of the contents of the cryoprecipitate. So storage is same as fresh frozen plasma. Okay. Cryo is used for treatment of factor 8 deficiency in hemophiliacs, that is at the initial process of managing patients with hemophilia. Cryoprecipitate was very, very helpful. But as technology advances and discovery goes on, we find out that cryoprecipitate, just as like blood transfusion, carry the risk of transfusing some infection. So Presently, there are current management protocols for hemophilia, but initially, this cryoprecipitate that is being prepared that contains the factor like factor 8 are being given to hemophilia. Also used in treatment of von Willebrand disease, but presently the use of cryo have decreased because of possibility of transmitting infections. Okay, factor 13 deficiency, okay, in all this, okay. Some of the clotting proteins in cryoprecipitate are available in specific concentration or in recombinant synthetic forms. So these recombinant synthetic forms, manufactured forms in the laboratory, are what is currently being used in the management of some of these patients. When these are available, they should be given in preference to cryoprecipitate to reduce complications. All right, thank you. Right, so we're going to stop here today. Thank you very much for listening. If you have any question, please, you can ask now. Thank you.